Hello, everyone, and welcome to the special episode of the multi-part series, Improving the Continuum of Care. My name is Dr. April Jasper, and I'm so glad to be here with Dr. Fechner. My practice is in West Palm Beach, Florida, and I see patients of all ages, including glaucoma patients, but I'm just excited to be here to spend time with you, Rob, and talking to our audience.
And I'm Rob Fechner. I'm a glaucoma specialist. I'm also in an academic practice now in Syracuse, New York. I have spent pretty much my whole career practicing in high income tax northeastern states where my patients disappear for 6 months in a day and usually to Florida. So it's great to chat with you, April, about how we can share and get the best possible care for our patients.
Yeah, it is really exciting. Dr. Fechner, you and I have talked about this together. And so now to be able to share our thoughts with others is going to be fun. So today we're going to talk about that providing uninterrupted care for glaucoma patients who seasonally migrate to warmer climates for the winter. We call them snowbirds. We can see quite a few snowbirds during the winter season in South Florida. Where I practice, these patients stay in our area for at least 6 months and 1 day. So, Rob, let's talk about the essential parts or the essential elements of keeping glaucoma under control.
Well, April, in the context of what we're talking about, the first thought that comes to mind is communication. It's communication between us and our patients and communication between doctor to doctor. We get very fragmented if you don't know what I'm doing and thinking, and I don't know what you're doing and thinking. And of course, the second piece is we just provide outstanding glaucoma care as always.
So there's different expectations from glaucoma screening tests and disease management. Not all those tests are comparable. So how do we think about that? What do we think about when a patient comes in? And then I guess the next question is, how does it help us to be more timely with treatment?
I think you make a great distinction, April, between the screening and then what I'll call the continuous care. Screening is an event. You have a test and it looks normal or not normal. What I'm not looking for on screening is for trend or progression. So screening becomes a much simpler concept for me than taking care of patients with disease where we need that ongoing testing to see how they're doing. With screening, there are a lot of platforms. I'm pretty agnostic about them. Once we get down to looking for continuity of testing, then I can't compare apples and oranges. I can compare apples to apples. In that setting, I love working with somebody who is on the same testing platform as I am.
I agree. It does make it easier for us to be able to look at the data and be able to understand it without trying to start all over. I think that's probably one of the most frustrating things on my end. So we talked about where we both live. I'm in Florida. You're in upstate New York, close to where I was born, actually. Let's now talk about what type of glaucoma can we expect to find in patients that you see in upstate New York who might be coming to South Florida during the winter.
Yeah, April, I wouldn't mind being in South Florida during winter either, but I do love upstate New York. I take care of the whole spectrum of glaucoma. And one class is the worried well, the patients we know will do well. And what they need is periodic reassurance. They need to know that their pressure is controlled. They need to know that their structure and function is maintained. For that group of patients, I think you have to show them. I love being able to show my patients in the exam room their test results and have that discussion with them. Then we get into the spectrum of patients who have established damage and or whose pressure has been a little more difficult to control. Those are the ones where working together really makes a difference.
I agree. So what tests do you recommend at different stages of glaucoma? You mentioned you take care of patients at all stages. And so what is your sort of protocol? I know it's a big question, a lot for a few minutes of discussion, but what is your protocol or your algorithm, so to speak, for stages of glaucoma?
We do treat stages differently, although what I call baselining or benchmarking is pretty consistent. We do a comprehensive examination. I always get central corneal thickness so I can interpret the Goldman applanation pressures. And then I want baseline field. I get a baseline OCT. And maybe I'm just a little bit old fashioned. I love having a baseline optic nerve photo because 5 years from now, 10 years from now, when I'm looking at that eye, I can't imagine I remember what my drawing meant, but I can see a photo. Once I have those as a baseline, that's where I diverge in how I might manage, test, or follow patients. We have the benefit of having Forum software running on our electronic health record. But whether you do or do not, the visual field guided progression analysis software has expanded my ability to find progression. And foundational to the software is I need at least 3 baseline visual fields before the software starts working. So if you're a new patient to me, I'm actually going to get 3 fields if I can within the first year to year and a half. One of the things this invites is the communication between you and me, because we can only do those analyses with the data within the field machine, not with the paper printouts. So I would have the conversation, do you want to get those baseline fields and be doing the GPA? Or shall I? And that's worth establishing. For the patients who have healthy fields, I'm not going to test them more than once a year. Or you can test them once a year. For the OCT exams, the analysis software is not quite as sophisticated as it is for visual fields. Visual fields have been around a lot longer than OCT. And I find I'm not expecting to see change. I don't need as many OCTs early. And I can use either of our OCTs to compare them and see whether there's signals of progression. Now, here's a problem. Our electronic health record, when I'm sending you records, faxes it to you. And the grayscale faxed OCT is next to useless. So one of the things I love to do is get a printout or send the colored image of the printout electronically. You got to have the OCTs in wonderful living color. For the severe glaucomas or the uncontrolled glaucomas, I see them more frequently. I'll see them every 3 months. If medical control has been unstable, I want you to know that. I want you to know what the pressures have looked like with me, and I want you to know what interventions I've had. So a change in my habit has been my notes now contain pressure and medication history, and it just gets copied over from note to note. The reason I think that's important is if you can see my last note, you can probably trace what I'm thinking. So when I'm preparing the patient's last note in, say, October, and I know they're going to be down in Florida for the rest of the winter, I'm going to give you a printout today of your last note and your tests, and I want you to hold on to these until you see your Florida doctor. That is the simplest way I know of to get you the information. And I think the patients really love knowing that we're going to be communicating with one another.
That's really good. I love that. I've not seen many people do that, so I appreciate it. And I think that's a lesson on both sides for better collaborative care. You know, the other thing I think is interesting is you talk about stages of glaucoma and how you move them to a different stage once you see visual field defects. What do you do for a patient? And I'm going to just give you a patient case scenario. And we haven't talked about this ahead of time, so this will just be spontaneous. But so my clinic day, typically, I have glaucoma patients all in between other patients. I try to schedule them early in the morning or early in the afternoon so that we can do our visual fields and OCTs and not get too bogged down. But they just are in the normal flow of patients. So there's a patient that I have that we have been following as a glaucoma suspect, no visual field defects. Pressures are hovering around 27. Cup to disc is about 0.6, and they're equal in both eyes. And he has a family history of glaucoma. His dad had glaucoma, pseudoexfoliative glaucoma, and he has not been started on treatment. And so he came in one day and he had a significant allergy. I put him on a steroid drop for what was going on with his eye. He came back a week later for me to check him. We checked his pressures, which we commonly do with red eye patients, and his pressure had gone up to 32 on this drop in that eye. So what does that tell you? How should I take that information besides stopping the drop? Does it change anything about how I care for him and his glaucoma risk?
Well, April, there's so many dimensions to that. Glaucoma is always complicated. And the answer to every glaucoma question always seems to be, well, it depends. So
Right.
in this setting, you've given me two clues. And one is there's a family history of pseudoexfoliation. And the other is this is a big time steroid responder. For them to come back after that short an interval with a high pressure, something has driven the pressure up. It also turns out that if we want to do a therapeutic intervention there, those are both two situations that can respond very well to SLT laser as first-line treatment. So I think as we look at the underlying glaucomas, we may pick medication first, we may pick laser first. From the description, this is actually a glaucoma suspect. If the nerves are symmetric and the fields are full and the OCTs are giving normal signals. So another very reasonable option is, rule of thumb, it takes as long for steroids to wear off as it took for them to wear on. So if this is somebody who spiked after a week, 2 weeks later, they may be back down to their baseline. And I'll tease you a little bit because you didn't tell me what the central corneal thickness was. Is it 600?
It was 600-ish. I think it was a little over, actually.
Yeah. So here's somebody who has, statistically elevated pressure, but in the context of that baseline examination that you and I do, we've benchmarked it. The
Right.
cornea is thick. The pressure is allowed to be a little bit higher.
Yeah.
The pseudoexfoliation says this is a high-risk glaucoma suspect.
And that's kind of why I put this one out there as a case to ask you, because in my mind, I felt the same way. This is a higher risk person than someone else. Likely he will go on to need to be on treatment at some point, but I like the idea of SLT first. That's a great tip. Okay, so let's talk about, you told me a little bit about your path as far as how often you do OCTs and visual fields. But the question I guess I have for you is, because glaucoma is a silent disease, and because we have patients just like this one who can have something happen. I mean, he could have gone to an urgent clinic and been given that same medication. And so how do you best care for these patients? And how often do you suggest OCTs and visual fields? You kind of covered it, but let me ask you one more time.
Surely. So we do see patients who've come in from the urgent cares and they've been on a month of a combination steroid antibiotic, and it's been a very bad idea. When patients are traveling between, and I'll just keep picking Florida and New York, because that is a very common pathway, isn't it? When they're traveling back and forth and they see you and they see me, and at least they're getting checked twice a year.
Right.
The high-risk glaucoma suspects, I would not see once a year. A pseudoexfoliator could go way out of control and be uncontrolled for 11 months and 29 days. So frequency of testing, to me, links to risk profile. For the glaucoma suspects, if their baseline pressures are higher without damage, we'll test more frequently. If they have pseudoexfoliation, we will test more frequently. And honestly, if they're just worried, we'll test more frequently. Because sometimes all we're doing is holding someone's hand and reassuring them that they're okay. For OCT, I typically go once a year. Is that your usual frequency?
It is. I don't typically, I like pictures as much as I like anything else. And I know you mentioned you take a baseline, and we really technically, as far as coding purposes, there are times when you can't take another photo for some of the insurances I'm on unless you see a change. But I really like those optic nerve photos, and I often give the patients the option of us doing that or not doing that.
Wouldn't it be nice if at the end of their visit, I take their chip or card or something, stick it into my computer, and they now have today's visit and the OCT in the visual field, and you can see it. Since I can't do that electronically, I love sending you my note, and I really appreciate when they show up in my office again with your note, or even a phone call. Hey, I was seeing Mrs. So and so, and I was worried about this. What do you think? Or Mrs. So and so is leaving for Florida next week, and we're not doing okay. Would you please take a look at her and let me know how she's doing? So communication to me is the bedrock for collaborating and taking care of patients. And just understanding that as doctors, we get very busy, but we provide better care if we work as a team and communicate.
Well, this is a conversation that it needs to include how you and I both use ZEISS equipment. So let's talk a little bit about the testing. So we have the same equipment, we have the same visual field, we have the same OCT. When we use the same technology and do the same test and the same progression analysis, how is that helping the two of us? We've talked a little bit about it, but how is it beneficial? Let's talk more specifically, especially for a patient that this patient we call a snowbird that's going back and forth depending on the season.
We have converged on the equipment we have, and we really haven't talked about the where or why for. And I do make the purchasing decisions for our Department of Ophthalmology. I'll just start out by saying we've had different platforms, but once we installed the Forum software, I now have tremendous progression tools at my disposal, as I'm sure you do as well. So we are migrating all of our OCT into the ZEISS instrument, and that lets me then get a structured function analysis. That's what I'm going to send you when they come to visit you. By having the same machines, even if the patient just shows up with a visual field test, I can look at their test parameters, compare it to their baselines and their trend, and it tells me how they're doing. If they have been tested on a different instrument using different test strategies, there is no reasonable way for clinicians to compare those. So for visual fields, it's just such a no-brainer to me. We actually have been running two different OCT machines because the retina doctors liked one and the glaucoma doctors liked the other. And if a patient got tested on one OCT and by mistake got tested on the OCT in the other room, it's going to be another year before I can compare apples to apples. So having a commitment to one platform and actually, to the extent possible, collaborating with somebody who's on the same platform is going to provide better patient care. So consistency of platform, consistency of testing, comparing apples to apples, and then having advanced analysis software that goes either way. I would love to see your GPA summary printout when the patient comes back to me.
Got it. So, Rob, tell me how this helps this whole concept of using this visualization software, Forum. How does it help you with educating patients regarding glaucoma and their progression or not progressing? Did I say that right? Yes.
I think I understood the question. And I'm obviously not in an exam room, or I would just swing the camera around and show you. But with the patient, you already really clued into glaucoma is without symptoms. And patients don't feel they have glaucoma. It doesn't hurt early on. They're not aware of any defects. So it allows me to swing the monitor to them and say, can you see right here? This is your glaucoma. Can you see this trend line over the last 4 years? It hasn't budged. You're doing okay. Here's the test right down here where I compared today's test to the ones from 4 and 5 years ago. If any spots had gotten worse, you're going to see black triangles. If there are not any black triangles, you're doing okay. Or conversely, I'm concerned. You're not in trouble yet. And if you never get any worse, you will never have a day's trouble in your life from your glaucoma. But can you see right here on this OCT exam? This is an area where you're starting to lose some of your optic nerve, and we don't want to let you lose any more. So for the patient, it gives them something they can relate to other than just my words. And I like to see things. I'm visual. I don't know that any patient really retains what we say to them if we're giving them a diagnosis or talking about progression. So having analysis software on my computer in my lane where I can just show them their glaucoma and show them that they're doing well, or show them why we're going to change directions a little bit, I think connects me more to the patient, and it's a win-win.
I think it also helps us to relate to our patient. Maybe I hope it helps them to be more compliant just because they don't want to score badly on that test when they come in the next time. And so I don't know, it seems to make a difference for me, for my patients, and maybe you as well.
April, I agree with you. And over my career, I started out where the doctor tells the patient what to do. And we now understand that really never worked. So it's partnership between doctor and patient. And by empowering the patient, here's what you can do to protect your vision. There's something you can do. I'm going to help you. But unless I stop at your house on the way home and put your eye drops in, I'm not really treating you. You're controlling your glaucoma, and here's how you can do it. And I don't know if it makes any difference. I feel better having that conversation. And I think with a lot of patients, it's an aha moment. So, April, I love having conversations like this. We are very much of the same mind. And for anybody who's watching and listening with us, I hope you've picked up on a few things today. We've got to collaborate. When care becomes divided with snowbirds, we can have a bucket in New York, or we can have a bucket in Florida, but opening up those communication channels, performing similar testing, and sharing our information is a win for the doctor in Florida, because you know what's going on in the context. It's a win for me because I now know what's happened during those 6 months in a day. And for anybody who doesn't realize it, it's that extra day that means you don't have to pay income taxes in the other state. And it's a win for the patient because they now have continuity of care through different providers who are communicating. I think this is a win-win-win. And the more we communicate, the more we are comparing apples to apples and either reassuring our patients or finding that progression early and pivoting our care to address it, the less preventable blindness we're going to see from glaucoma. And isn't that really what it's all about?
Absolutely.